moment. Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session is perioperative consideration in cardiac transplantation. Now, I would like to invite Dr. Muralidhar Kanchi sir to proceed. Over to you, sir. Thank you.
Good evening and welcome to the ICA Wednesday webinar. ICA stands for Indian College of Anesthesiologists, which is an academic body dedicated to imparting education to trainees as well as for the practitioners of anesthesiology. And in fact, the webinars on Wednesday have become a constant feature and popular feature of Indian College of Anesthesiologists. With this short introduction, I am also happy to see Dr. Jayashree Sood, the president of Indian College of Anesthesiologists, with us, in addition to all the other faculty members. Thank you so much, Dr. Sood, for joining us.
Thank
Today,
you. Pleasure.
thank you, thank you, sir. Today, we'll be dealing with heart failure, the perioperative considerations. It's a sort of multidisciplinary approach. We have a intensivist and cardiac surgeon amongst the anesthesiology crowd. So we will be able to have input from them regarding their, how they look at heart failure and how we can together make a difference to these patients with heart failure. As you are aware, heart failure is a global disease which has a dismal prognosis. In fact, up to 30% of patients with NYHA class 4 die in 1 year's time, and about 75% die in about 5 years despite optimal medical therapy. So heart transplantation is the only life-saving measure in these patients. And hence, we would like to deal with this subject in a little succinct manner today. And I should also mention here that today is a this Guru Purva, which celebrates as Kartik Purnima here. I would like to wish you all a good best wishes on the occasion of this festival. And also, I would like to mention that Narayana Hrudayalaya was in the news for two reasons in the last 1 month or so. First one was that we did 3 transplants, heart transplants within 12 hours. 3 transplants within 12 hours. That is one news. The second news why we were in the papers was that we could transport the donor organs of through a distance of 33 kilometers uh, using the metro connectivity. This is a bit interesting news. So with that introduction, I would like to request Dr. Sood, do you want to say anything?
No, that's fine, Dr. Kanchi. And I'd like to welcome all our colleagues today and looking forward for this webinar. Thank you.
Thank you. Thank you. Thank you so much. I'm also grateful that we have our surgeon and intensivist colleagues joining us, and it should be interesting. Uh, to begin the program, I would like to introduce my moderators. Dr. Poonam Malhotra does not need any introduction. She's a very well-known cardiac anesthesiologist of international repute. She's also having extensive experience in anticoagulation and ECMO. And the second moderator is Dr. Sanjay OP, again a very accomplished cardiac intensivist working with us. Again, extremely knowledgeable and well-known. Third moderator is Dr. Chintan Seth from Ahmedabad, young but very accomplished. Very nice to have you, Chintan. Thank you so much for joining. And I'll be with you throughout the session and request you to put your questions or comments in the chat box. We would like to address them at the end of all the 4 talks. And now it's time for us to go with the session. I would like to request Poonam Malhotra to introduce the speakers and take it up. Thank you so much. Dr. Poonam, are you there? I would like to introduce Dr. Nandita, who is with
Yes,
us.
I'm there. I'm there, sir.
Yes.
Dr. Nandita is the first speaker, and we begin the perioperative condition considerations in cardiac transplant with a female on this Prakash Utsav Nana Jayanti. I think before we talk about preoperative preparation and considerations in cardiac transplant, Dr. Nandita is a budding intensivist anesthetist. She's doing her postgraduate training in anesthesia critical care and is very apt to talk on what are the preoperative considerations and preparations needed in a cardiac transplant patient. Over to you, Nandita.
Good evening, sir. Good evening, ma'am. Thank you so much for the introduction. I'd like to share my screen now. Yeah. Is it visible? Can I start the presentation, sir?
Yes, please go ahead. Please go ahead, doctor.
Yes. Good evening, everyone. I'll be speaking on preoperative preparation and considerations for patients being posted for heart transplant. So the first question is, which subset of patients require the heart transplant? The subset of patients requiring, sorry, these are the subset of patients who progress to heart failure patients who progress to advanced heart disease despite maximally tolerated guideline and guideline medical and device therapy. They are usually highly symptomatic heart failure patients or those with cardiogenic shock, uncontrolled ventricular arrhythmias, or in some cases with congenital heart diseases after surgical palliation has failed, or those with cardiomyopathies. Now, there's a quick guide to identify patients with advanced heart failure, and the popular mnemonic is I need help, wherein each letter stands for the corresponding criteria, wherein I stands for the inotropes, N stands for the NYHA grade 3 or grade 4, or NT-pro or pro-BNP or BNP. E stands for end organ dysfunction, and the other E stands for ejection fraction less than 20%. D for requirement of defibrillator shocks. H is for hospitalization within the last 12 months. E for edema. L for low blood pressure, and P for prognostic medication. Now, starting with the evaluation, the comorbidities have to be assessed. And apart from that, the age, patients with cancer, the frailty, pulmonary disease and hypertension, infections and surgical risk all have to be accounted for. In terms of comorbidities, the most common one is diabetes mellitus, and around 30% of the patients have pre-existing diabetes. The recommended guidelines tell that the HbA1c should be controlled and it should be within 7.5%, because diabetes in itself is not a contraindication, but the aftermath of diabetes, which includes obesity or kidney dysfunction, puts the patients at a higher risk, and also post-transplant use of steroids and calcineurin inhibitors further worsen the glycemic control. Now, in terms of kidney disease, a thorough kidney evaluation has to be done, which includes mainly EGFR and a 24-hour creatinine clearance, and they have to be assessed every 3 to 12 months, because usually the transplant patients are not someone who are identified immediately and put on and are taken away for surgery. They usually have a long waiting period and therefore require repeated assessments every now and then. And if the GFR is less than 30 for more than 90 days, the patients should ideally be posted for a heart and kidney transplant. Similarly, the liver diseases have to be evaluated, and the liver function tests, biochemical assays, MELT score, and the abdominal imaging are to be assessed. And along with that, if the patients have biopsy-proven cirrhosis, or if the gradient between hepatic wedge pressure and hepatic vein pressure is more than 5 mm of Hg, ideally the patients should be receiving a heart and a liver transplant. And the connective tissue diseases are also to be equally assessed. In case of comorbidities, apart from the others, obesity is also an important criteria, and it has been recommended that BMI more than 35 kilograms per meter square are associated with significant mortality and morbidity. So these patients are advised to undergo a bariatric surgery if at all it is required. And the vascular diseases are also to be assessed. Those with any kind of a prior history of stroke, a carotid ultrasound is recommended, and for those with a documented peripheral artery disease, ankle brachial indices are to be monitored. In terms of age, there's always an ethical concern. Patients more than 70 years of age, it's not recommended, but it's not a contraindication. The concern is being with regards to the use of the scarce resource of young hearts for the older recipients. And more patients may need dual organ transplantation, which puts them at further risk. In terms of cancer, skin cancer rather is a major concern for post-transplant, as it affects both the quality and the quality of life post the transplant. And in such cases, collaboration with an oncologist is extremely essential for risk stratification. And rather a new index of frailty is to be always assessed. Frailty is not just restricted to age, but it is rather a physiological response to stressors. And the most common used instrument is a frailty phenotype, which focuses on 5 domains. And these are the criteria usually assessed, which is physical exhaustion, weakness, weight loss, which is replaced by loss of appetite, slowness, and low physical activity. The next to be assessed is the pulmonary disease and pulmonary hypertension. And usually pulmonary function test is to be done, which includes spirometry, lung volume assessment, and a chest CT. The defined criteria for a pulmonary hypertension is where the mean pulmonary artery pressure is more than 20 mm of Hg, and most commonly these patients have type 2 type of pulmonary hypertension. One point has to be noticed that patients are deemed ineligible for heart transplant if the pulmonary hypertension is irreversible. An isolated heart transplant is rather a contraindication. They may be considered for heart and lung transplant in carefully selected patients. For assessment of pulmonary hypertension, it has to be noted. It has to be taken care that we have to check whether the pulmonary hypertension is reversible or not. And for this, 3 criteria are monitored: pulmonary arterial systolic pressure, or the transpulmonary gradient, or the pulmonary vascular resistance. Acute vasodilator challenge is given, and if not, a diuretic therapy is added, and ultimately a trial of mechanical circulatory support is also given. Despite all this, if there are no changes, or rather there's no decrease in the above 3 values, the patients are not put for an isolated heart transplant. And if the values decrease, then the patients are listed for transplant. And obviously, the transplant patients are rather highly immunosuppressant and susceptible to infections. Hence, a thorough screening and a proper vaccination is also to be done. Any kind of previous cardiac surgery also increases the morbidity and mortality. And it also has to be noted that patients who have had a previous mediastinal radiation, especially the cancer patients, are at a high risk of something called as the porcelain aorta. And in such patients, the benefit is rather questionable due to the high risk of perioperative mortality and stroke. And this, because of the long standing wait list, and it takes a toll on the mental health of the patient, and therefore a psychosocial evaluation is of utmost importance. Patients with substance abuse, it is always recommended that the abstinence is maintained for at least 6 months or more if possible, and there has to be a continuous surveillance for these kind of substance abuses. And there has to be a proper evidence of social support, adherence, and adherence to medications. And there are recommended standard tools for assessment. I'll just quickly run through the slides with regards to the assessment. And it always has to be noticed that it is not an isolated team that takes care of such transplant patients. It is a multidisciplinary team which involves surgeons, the transplant specialists, the infectious disease team, and the cardiologist, social worker, transplant psychiatrist, the patient, and more importantly, the social support for the patient. In terms of preoperative optimization of patients on wait list, it has to be both pharmacological and non-pharmacological. In terms of heart failure medications, the medications are continued to their maximum tolerated doses, which includes ACE inhibitors, beta blockers, mineralocorticoid receptors, and SGLT2 inhibitors. And for decongestion therapy, which includes diuretics and volume management, they are to be used at minimum doses. Those patients who have had any kind of ischemic heart disease, their anti-anginal medications are to be continued for symptomatic relief. For pulmonary hypertension therapy, it is recommended that the phosphodiesterase 5 inhibitors, that is sildenafil, is recommended, but it is not recommended to use the other drugs, which are prostacyclin derivatives and endothelin antagonist drugs. In terms of anticoagulant and antiplatelets, it is recommended that vitamin K antagonist and heparin-based agents be used because their reversible agents are well known to us. For vitamin K antagonist reversal, we have vitamin K itself, fresh frozen plasma, and prothrombin complex concentrates. Your use of the newer direct oral anticoagulants is rather challenging because their reversal is questionable. And in terms of antiplatelet therapy, P2Y12 receptor antagonists are to be avoided if possible in order to reduce the risk of bleeding. And if the patients require any kind of percutaneous interventional procedures, say for a secondary MR wherein the ejection fraction is low, and or any kind of heart rhythm changes, the appropriate percutaneous interventions like a mitral transcatheter H2H repair or an ICD or CRT or catheter ablation, it is advised to subject the patients to the appropriate therapy. And because these patients, as I would like to repeat the point that these patients are always on a long wait list. So there are specified guidelines to repeat the tests every now and then based on the clinical status of the patients, because sometimes the patients may be on the waiting list for more than a year. So a serial right heart cardiac catheterization has to be done every 3 to 6 months while awaiting heart transplant. The vasodilator challenges have to be assessed to check for the reversibility of the pulmonary hypertension, and temporary mechanical circulatory support if the medical therapy fails in order to achieve any kind of hemodynamic stability. And reevaluation has to be done every 3 to 6 months. Similarly, the cardiopulmonary exercise test, kidney assessment, and the liver function tests and vaccination screening have to be evaluated every now and then as per the clinical status of the patient. Serial cancer screening, psychosocial assessment, assessment of malnutrition, frailty, HLA antibody are also to be done. Now, during this waiting period, the patients may improve or may end up in acute decompensation. If the patient improves, the ambulatory patient should be reevaluated, and if significant improvement is seen with the pharmacological and the non-pharmacological methods, the patients can even be removed from the transplant list. Post delisting also, the follow-up has to be continued to identify any kind of deterioration. However, unfortunately, if the patients end up with acute decompensation, their statuses do get upgraded for a in the transplant list, and in the periodic administration of inotropes and the drugs have to be considered. And there is a use of novel oral vasodilator called Verisugart, which can be considered in such high-risk patients. And however, if the patients do not wish to go ahead with it, the end of care and removal from the wait list should be done with adequate emotional support and with the emphasis of maintaining that an acceptable quality of life is there for the patient at the end of the day. I'd like to end my presentation here. Thank you so much.
Thank you, Nandita. Dr. Mulidhar, is it okay to ask a small question or give a comment right now or at the end?
Are you available till the end?
Okay, good, good. I'll be there.
If you are there, you will ask the question at the end.
Okay.
Because it
Perfect.
will be a sort of
Perfect.
panel, we can request others also to comment on the reply, etc. So it will be easy.
Very nice.
Thank you so much.
So we continue with the next lecture coming up by the surgeon par excellence, Dr. Julius Punen, a great friend, a benevolent cardiac surgeon, and a person who I think has risen the bar for cardiac surgery nationally and internationally. It's our pleasure to listen to how Dr. Julius does the surgical techniques tackling of cardiac transplantation. Over to him.
Thank you, Punan, for the kind introduction. Can you see my slides?
Not yet.
I think I am sharing. Is it seen now?
Not yet. Rimpa,
No.
can you help Dr. Julius? Venkatesh? Now it's coming.
Okay.
Yes.
Perfect. We can see now.
Thank you very much for the opportunity to speak to all of you. It is not very usual for me to be speaking outside of a cardiac surgical community. Now, in this talk, I was going to speak about how a cardiac transplantation is done rather than saying how to do it, because since I'm addressing a non-surgical audience. So I was going to speak about the donor operation, recipient cardiectomy, preparing the donor heart, and the various anastomosis and the conclusion. What is to be remembered is that the success of a transplant begins with a donor operation. I would like to quote Professor Wahlberg. He said, "You cannot make chicken out of a fried egg." So if you fry your donor heart while you're retrieving or transporting or at any point of time, you're not going to have a successful outcome in the heart transplantation. It sounds very sensible, but it is something which you have to take a lot of care about, because a lot of times we delegate donor operation to the junior most member of the team, and then you may have difficulties with various other teams also. Okay, when you go for the donor retrieval, first thing is to verify the brain death, the consent, police clearance, all of these yourself, because the punishments in the act is very severe, and at the end it will be the surgeon who's standing there holding the baby. So it is best that you verify everything yourself. Have a chat with all the other teams and decide on the way you would go about doing the retrieval. And there are structures which you need to share between the we have the IBC, which goes between the lung, between the liver and the heart, and the LA, part of the LA and the PA again get shared by the lung team and us. So it's good to have a little discussion with these teams prior, and always tell the anesthetist to the dose of heparin you want to give. And it is a good idea to always give muscle relaxant to these donors, because suddenly you'll have a spinal reflex and the hand goes right up, and then everybody's confused about what to do with the brain death declaration, etc. So once you've done all this, also check with the anesthesia tech that you have enough suction machines in the room. I have hardly ever done a retrieval where the suction is not gotten full, and at the crucial time, the suction is not failed. So whatever you tell them, they will not anticipate the amount of fluid that comes out of the field. So when you're doing a donor cardiectomy, the idea is to get as much tissue as possible. You can always trim later. So you have to also keep in mind what your recipient anatomy is, particularly when you're doing pediatric cases where suppose there is an LSVC. you may have to take the entire length of the innominate vein in order to connect the LSVC back. Or if you need to do an arch reconstruction, you may have to retrieve the whole heart. And always take some additional pericardium. Pericardium was provided by nature for the cardiac surgeon's use. There is not much other purpose for it. So when you're doing the retrieval, it is a multi-organ retrieval. It looks something like this. All the body cavity is exposed. Everybody works together. Usually there may be some time differences. And also everybody plays some games or the other based on what time their recipients are getting in and getting ready and all of that. So just accommodate all of that while you're doing this. When you're doing the donor cardiectomy, you have to mobilize all the structures as much as possible at that site, because you can also do it later after you retrieved it, but it is easier to do all the dissection in the anatomical position as you're familiar with the way it lies. So you need to loop the SIGOs and tie it, and put a loop on the SPC, which you can tie later, and again loop the SPC, IVC and aorta. And once others are all ready for their retrieval, you have to give the heparin, and they will be tying the abdominal aorta, and then the pressure tends to go up at that time. And once you tie off the SVC, then the return comes down, and then that comes, then that'll manage the pressure better. And you would divide the IVC at a place where it is convenient for, there's enough tissue for you and for the liver group also. And after you've divided the IVC and vented the left side, then you place the cross clamp and run the cardioplegia. We usually use custodial about 2 liters, which is run over 8 minutes. And once you finish the once you put in the cardioplegia, you have to make sure that the cardioplegia is flowing well by looking at the coronaries and making sure that change color to transparent from red. And also keep ensuring that your LV is not distending by palpating it with your finger. And if it is distending, you may have to vent further or put a sucker through the LA into the LV and suck it out. And once you've done this, you complete the incisions. You divide you just sort of go anti-clockwise, divide the IVC, the left pulmonary veins, the RPA, then the aorta, LPA, right pulmonary veins, and the whole thing can be removed. Then once it's removed, you triple bag the heart, and generally we bag it in a liter of custodial, and then you keep it inside a ice box and transport it to your facility. So at the same time, you have to do the recipient. Once we have given the go-ahead from the donor side, the recipient surgeons will do the recipient cardiectomy as we are traveling. And there also you would divide the aorta, and generally you divide the anterior structures first, like the aorta and the PA and SVC, then IVC, and finally the LA. LA would be divided as a cuff. See, 1 second. See, you would be left with an LA cuff like that when you're going to do a bicaval anastomosis. If you're doing a biatrial anastomosis, you would preserve the right atrium and the left atrium separately. Here, the cava are divided and the LA is separate. Okay, so we won't be discussing biatrial because that is not done so much now. So I have this former student who is a consultant now made all these nice diagrams to illustrate how these divisions are performed. So you can see the aorta is divided here, SVC is divided there, and the IVC is divided there, and the PA is divided. And we place these little marking sutures anteriorly so that you know what is anterior once the structure is floppy. And you can align your, you also place similar marking switches on the recipient, the donor also. So you can align these to get a reasonable alignment. So this is the donor cardiectomy, where you incise the LA. And then, as I said, you would go about, you would be snaring the cava, and you would divide the anterior structures first and take this incision backwards, and all these structures are divided, and this is removed. Usually we give some cardioplegia prior to the recipient cardiectomy for two reasons. One is that it is easier to handle a heart which is still, and it is a very sad looking sight if this heart is sitting outside in a basin and going on beating slowly as it is giving up. So just to avoid that, we give a little cardioplegia to arrest it. So then the whole so this is the way you would be seeing the LA. The mitral valve will be there. Your incision will go right under the mitral valve. And again, the appendage is also removed. And either you can put a mark here with a suture so that the appendage can be used for aligning your recipient heart to this one. Because doing the LA anastomosis correctly and properly is the most important part. Okay. So once you've removed the heart, this is what the cavity will look like. You have the whole of the left atrium into which the pulmonary veins are draining. You have the main pulmonary artery, aorta, SVC, and IVC. You leave all these structures as long as you can, and then you can trim them as you place the heart. I have some videos, but it might take such a long time to play the video, so I'll just try and run through them quickly. I'm not able to fast forward this. Anyway, okay, I'll just skip the videos for now. There is time later, we can come back to it. There are some preparations which you need to do to the donor heart. One is to separate the aorta from the PA and the LA from the PA so that you get enough tissue to work with. Inspect the valves, look for any PFO. If there is a PFO, you must close it. I think Murli might disagree with me, but the recommendation is to close the PFO. And if there is a valve at the IVC, you need to excise that. Otherwise, that might come in your way sometimes. And you have to prepare if you're doing a bi-atrial anastomosis, you'll have to prepare the atrium by dividing it like that. In a bicaval anastomosis, you would be making the pulmonary vein into one chamber by cutting them across each other. So as I said, this is how we separate the roof of the LA from the PA. So when you turn the heart around and look at it from posterior, it can be very easy to get very confused with the various structures. So that is something which one needs to get familiar with. And for the pulmonary veins, we join them across like this, and that makes it into a big chamber. But if the lung is harvested, this portion of the LA back wall goes with the lung team. Again, I'll skip the video. And for the inflow anastomosis, what we do is the LA first, which is the posterior most structure. You would put a marker at the appendage where the appendage was and align the same with the donor heart's appendage. And you would run that. You can take an additional marker and then you just run the stitch and complete the LA anastomosis doing that. Once we do the left atrium, this is how the LA anastomosis is shown in this diagram. And once we do the LA anastomosis, now what we do is we do the aorta next and release the clamp. But if you're not feeling up to it, you can do the other anastomosis like the PA and the IVC without releasing the clamp. Now, it is a bunch of circular structures which everybody would have a way of stitching one to the other without causing torsion or kinking. So in order to prevent kinking, you may have to keep things short. Once these systems are done, scaling. So again, IVC and SVC are done separately. We do it off clamp, so we just leave a suction at the coronary sinus there so that you're not flooded too much. You can do it on clamp also if you think that is a problem. So these are the anastomosis. You have the SVC, aorta, the PA, and the IVC, right? So once you've done that, a lot of times you may need some pacing because the heart is denervated. And remember, many of the drugs work differently. For example, the atropine is not going to work on a transplanted heart. And all these drugs, some of them work at a lower dose, some of them work at a higher dose. And I think we have Murli talking about PGD, so ECMO would be probably covered there. So de-airing is very important because if the RV is not working, which happens a lot after transplant, you don't want to be worried about that it is air. So that's that. So thank you very much. I'm not going to cover the biatrial transplant. So these diagrams were from Namdev, and the video, which I could not show you because of lack of time, was from Terry Yao. Thank you.
Thank you, Dr. Julius. I think it was wonderful, small synopsis, which gave an overview of how the surgical techniques in cardiac transplant can be done. And you showed it beautifully through the diagrams. And we'll have questions for you at the end. Thanks for joining in. We now move on to an ace anesthetics, a great as well as neuroanesthetist, Dr. Raghu B., a senior consultant at Narayan Vidyalaya. He's been there since the start of the echocardiography course and the brilliance of echo, and his cardiac anesthesia leadership shows. He would be talking to us today about anesthetic considerations in cardiac transplant. Over to you, Raghu.
Thank you, ma'am. I'm sharing my screen.
We can see it.
Julius, sir, can you unshare your screen?
Could you unshare this?
Okay, good evening, everybody. Sir, can you see my screen, sir?
Yes, we can. We can, Raghu. Please proceed. Challenges in anesthesia.
Yeah, good evening. Today I'm going to talk on challenges in anesthesia in a cardiac transplantation thing. I'm going to talk in these headings: recipient patient related challenges, and after the transplant, what other things we can face is the RV dysfunction, the vasoplegia syndrome, the primary graft dysfunction, and the bleeding. Coming to the preoperative assessment, we usually get a transplant call just few hours before the surgery. Should look at whether the patient is NPO or is on for just had his dinner, or you should also check whether the patient had the previous surgery like the CABG, or patient having AICD implantation for his arrhythmias because of LV dilatation, or patient has underwent ECMO or having an LVAD. And we should always confirm the symptoms with the patient, because many of the patients with viral myocarditis will be on treatment, and you should always check in trans thoracic echo. How about the LV function? Is the LV function improving or not before we take the patient? And most of these patients will be on Mildrenon injections, or IV home infusions, or will be having an anticoagulants with all these things. When you receive a call for the cardiac transplant, the recipient patient should be sent for all the blood investigation, blood group typing, and if the patient is receiving warfarin like in LVAD patient, you should always arrange for FFP and other products. And you should always wait for the call from the organ procurement team to go to the OR. Consider always the transport distance, whether the organ is coming from the same city or from a distant city, or if the patient has underwent previous surgery, so the time taken for the dissection will be more. So you should always coordinate with all these things with the procurement team, and then start your induction. And if there is an AACD in situ, you should always call the company fellow to deactivate it, or to know the status of the this one, what is a program there, and we have to ask him to put an asynchronous mode. So, but just before the before we induce the patient, or the patient can be wheeled into the OT, all the monitors in situ, have a wide bore IV cannula. We usually practice of putting the left femoral arterial cannulation, and awake central line and PA catheter are inserted. They check the SVR and PVR. As most of these patients, the cath would have been done 6 months to 1 year ago. And if the patient is undergoing a redo, if it is a redo case, the defibrillator paddles are placed before the induction. Once the donor heart assessment is done by the procurement team, that is seeing usually is there any laceration on the donor heart or any trauma, or the calcification of the coronary arteries have been done, and if they give us a sign to induce the patient, we can induce the patient. And just before induction, we can give the immunosuppressants. Here we follow oral tacrolimus 1 milligram, and MMF 500 to 1 gram IV is given, and injection methylprednisolone 500 milligrams is given, and antibiotics according to the institution protocol is administered, and then the patient is induced. The main goal of anesthesia for inducing a cardiac recipient patient is you should always slowly titrate the anesthetic and adjuvant agent selected for the induction to avoid hemodynamic stability, because once there is a hemodynamic instability in these patients, it is very difficult to response to vasoactive agents administered to treat acute hemodynamic instability, because all these patients will be chronically exposed to inotropic agents. So we usually induce the patient with injection fentanyl 2 to 3 mics per kg, with edomidet 0.3 milligrams per kg and midas 1 milligram, and a rapid sequence induction is done with injection rockurine 1 milligram per kg, and it is maintained with isoflurane with opioids and muscle relaxants. And after the induction, we put the TE probe, and this is a patient where we can see the dilated cardiomyopathy. We can heart is dilated, and we can see the trabecal lesions in the LV. And once we did the GLS for this patient, we can see the GLS is less than zero point 0.3 to 0.8. And this is one more patient who has got dilated cardiomyopathy. You can see the LV thinning out, and the contraction is not much. This is one of the pediatric patient where this is a right ventricular arrhythmogenic RV, where we see the RV is dilated and non-coaptation of the tricuspid valve was there. These are the cases which the recipient patient had the diagnosis. After once we get the call from the donor procurement team that they have harvested the heart, here we will do sternotomy. After giving heparin, aorta, SVC and IVC are cannulated and initiated on bypass, and the aortic cross clamp is applied, and the recipient heart is removed. Once the the donor heart is placed, the aortic and LA anastomosis is done. We give injection methylprednisolone 500 milligrams IV before the cross clamp is removed, and the PA, IVC, SVC anastomosis is done after the cross clamp is released. And usually we try to wean the CPB. Once there is adequate de-airing is done with TE, and the reperfusion time is more than 60 minutes, and CPB can be weaned, and this heart, the donor heart, is denervated. That is, there is an absence of sympathetic and parasympathetic nerves, so it doesn't respond to injection atropine. So the rate and the rhythm has to be taken care with drugs like epinephrine or isoprene injection can be started. The rate patient can be put on pacing at DOO at the rate of 60, and these patients should be adequately preload, and you should maintain the contractility with optimizing the RV contractility after starting the inotropes. Now, post CPB in the TE, we have to assess the RV and LV function, look for any turbulence at the aortic, pulmonary artery, pulmonary vein, SVC and IVC anastomotic sites. And this is a patient where when once we come off bypass, we could see turbulence at the SVC, and we got the gradient of around 11. This was a pediatric patient where we have taken an adult 42-year-old patient as a donor heart, and when we did at the this one, we could see some turbulence. We checked with the needle pressure at the SVC and at the anastomosis above and below. The gradient was more than 12, so we went back and we augmented the SVC, and we could see in transgastric bicable view there is no turbulence. The gradient what we got was 5 mm. So we should always look at the SVC and IVC anastomosis, and we should look at the LV and RV function. If there is any PFO, all these things we have to check. But once the case is weaned off, and this is RV strain pattern which we check after the transplant. See, one of the commonest problem after the cardiac transplant is done, we see RV dysfunction in the recipient patient, which is of the donor's heart. The sequence of insults in the donor heart occurs mainly because of the brain death, the cardioplegia, the ischemic time, the reperfusion injury, and the cardiopulmonary bypass interaction. And other factors which contributes for this RV dysfunction is the recipients pulmonary hypertension, long CPB time, and the air present in the myocardium. See, these are the things which can be seen in the echo. Most among all these things, the sensitive one is the RV fractional area change. If it is less than 35, that means there is an RV systolic function. This is a TAPSE. We can get from the deep transgastric view, and this is the S prime. If you put a pulse rate Doppler at the lateral tricuspid annulus, we can get the S prime. Usually, if it is less than 10, that means the RV dysfunction area. This is the RV fractional area, where the fractional area is calculated by the end diastolic area minus the end systolic area divided by the RV end diastolic area. If it is less than 35, it is the RV dysfunction is present. And this is how the RV strain also can be calculated. The main goal in treatment of RV dysfunction is preload. Always avoid the RV to be over distended or underfilling. If it is over distended, it is better to remove the fluid from the myocardium, either by doing muff. If the patient is still on CPB, we can do muff and you can remove the volume, or if the patient is underfilled, we can give volume and get the CVP high. And you should always take the afterload, that is lowering PVR, pulmonary vascular resistance, either by starting nitrates, prostaglandins, or by inhalation INO. And always you should keep the ABG to be normal, that is the PaO2, CO2, all should be in normal range. And you should maintain the adequacy of the donor's heart contractility, either by starting injection dobutamine at 5 mg or by milrinone, or increase the RV coronary perfusion by starting the inotropes, vasopressin or norepinephrine. And one more commonest problem what we see in this transplant patient is a vasoplegia syndrome. This occurs because there is a refractory hypotension during or post CBB related to vasodilatation or to catecholamine resistance. Usually it is seen in 30% of the patient, and 10% it is severe. Most of the things are diagnosed with when we come off. Usually we pull the PA catheter up to the sheath level, and later on after the SVC cannula is removed, we advance the PA catheter into the PA and check for the indices SPR and PVR. If there is a decrease in the mean arterial pressure with a decrease in the CVP and decrease in SPR with the cardiac index is increased, then it is vasoplegic syndrome. Always it should be treated with adequate volume and vasopressors, and the mortality is very high. It is around 19%. And the main risk factors for this vasoplegia syndrome is the patient factors, that is the myocardial dysfunction, is a patient diabetic diabetes mellitus, or patient having a thyroid disease, or patient is on mechanical circulatory support, and the preoperative drugs like injection heparin, calcium channel blockers, or the beta blockers, or if the patient has underwent a heart transplant or a VAD or endocarditis or on CPB, and other factors which can lead to have vasoplegia, the protamine, the long-standing CPB, the transfusions, and IABP. And this can be treated with vasoplegic syndrome. Always you should have a target of mean arterial pressure of more than 65 mm of Hg, which can be done by using injection noradrenaline up to 0.01 to 0.2 mics per kg per minute, or vasopressin like 0.01 to 0.04 units per kg per hour, or epinephrine can be used. Or if it is not responding, we can give injection methylene blue 1 to 2 milligrams per kg for fourth hourly, and it can be repeated up to 3 times. Other drugs which can be used for treating vasoplegia are hydrocortisone 100 milligrams IV 8th hourly can be done, and thiamine 100 milligrams 6th hourly can be given. Vitamin C can also be used, and hydroxycobalamin 5 grams can be used. And with all these things, we have to give volume expansion and discontinue vasodilators if there are any dilators like dobutamine, milrinone. All these drugs has to be discontinued, and it has to be treated. And one of the commonest, this one is early graft dysfunction, where we are not able to wean from this CPV with the standard dose of inotropes. The primary heart dysfunction can be diagnosed when the secondary cause is not identified, or may not involve an isolated dysfunction of the left ventricle or the RV, or it may be biventricular, which we are going to discuss in the next session. And one of the commonest challenging factor for the anesthetist is the bleeding, particularly in a redo case or a VAD case. Most of these patient risk factors are, most of these patients will have hepatic dysfunction, or patient can be going for reoperation, or patient may be on LVAD, or patient can have a prolonged operation. All these factors increases the bleeding. And the preoperative risk factors, other preoperative risk factors are patient is on warfarin, where at the induction we can give vitamin K 10 milligrams because it takes 4 to 6 hours to act, or we can have prothrombin concentrate complexes can be arranged to give it to the patient post-operatively. And and adequate blood and blood products has to be ready. Intraoperatively, how we can do is we can save we can reduce this bleeding tendency of these patients are by using the cell saver. We can start antifibrinolytics like tranexamic acid, or we can do rotum testing, or blood and blood products can be given, or if required we can use prothrombin complex concentrate factor 7, or the fibrinogen powder can be used. And in summary, heart transplantation is the best option for survival. Both the recipients and the donors have changed, but the anesthesia and the surgical techniques are unaltered. Always recognize and manage the vasoplegia, right ventricular dysfunction, primary graft dysfunction, and bleeding. Thank you.
Thank you, Raghu. I think you gave a very good brief outline in the time limit provided. Great insight into what anesthesia challenges and considerations should be. We now go on after the anesthesia part to the next most dreaded part. After the surgical correction and particularly looking for gradients across the PA anastomosis, as Raghu pointed out in TE, we're very, very scared of so many post-operative complications. And who better than Dr. Murli Krishna T from MGM Healthcare, Chennai, an ace cardiac as well as lung transplant perioperative physician who I've had the privilege of working for a short time at AIIMS, New Delhi. And he is so well versed in managing these post-op complications, whether it is primary graft failure or whether it is any kind of right heart failure and other complications, that it will be good to listen to him and his words of wisdom on post-op management of the cardiac transplant patient. Over to you, Dr. Murali Krishnan.
Good evening, ma'am. Thank you for the kind words. Thank you, Murli sir and the team for the opportunity. Can you see my screen? Presentation is visible?
Yes, it is. Yes, it is.
Okay. So over the next 12 minutes, let's look at like how do we handle the post-operative care of a transplant patients. One second. Okay. I'm Dr. Murli. I work as a senior consultant at MGM Healthcare. This is what we're going to look. Let us first look at the regular care. What do we do for this patient? And let's briefly look at the complications, what we commonly see in the post-operative period, the PGD, RV dysfunction, rejection, infection, and the other complications. To start with, the post-operative care of a transplant patient is like a regular care of any cardiac surgical patient. Apart from that, you are a little cautious on few aspects. One, your infection control measures will be very strict in these patients. And second, when it comes to the monitoring, not just the arterial pressure and the CVP, you monitor the cardiac output, PA pressure, SVR, and PVR in all these patients. Rather, that is what is being recommended or suggested by the different societies pertaining to this. As you see below, you always need to have a cardiac output monitoring in this patient. A special mention about the echo. We need to keep a watch of the cardiac function of this patient with the echo regularly. But because of the disparity in size between the pericardial cavity and the new heart, a good transthoracic images are usually difficult to get. In cases where you don't have a good transthoracic images, we should always have a low threshold in if you are dealing any situation to just put a T probe and try to get a good image of this patient. Otherwise, like any other regular cardiac surgical patient, you try to wean and extubate this patient maybe within 12 to 24 hours. Before that, if the patient is on nitric oxide, you wean off and see whether the patient is tolerating. Then get them off the ventilator and keep a close watch on all possible complications like a bleeding, infection, or a cardiac dysfunction. Gradually taper the inotropes. As you're tapering these inotropes, look at the parameters, your hemodynamic, your echo, whether the patient is tolerating tapering or not. Along with that, since it's a transplant case, you target your immunosuppression therapy, and roughly say at the end of a weekdays or so, you plan an endomyocardial biopsy and get a biopsy done. And once the patient is off all these things, if the biopsy report is acceptable, then you plan shifting out of the patient. Typically, not less than 7 days, even if the patient is perfectly stable, roughly around 8-9 days in our unit. So coming a brief intro about the immunosuppression, it starts from the theater or starts in the preoperative period itself. The standard induction therapy, the drugs commonly used are the basiliximab or the ATG. If both of these are not available, then a steroid induction can be considered. Your maintenance is always a 3-drug regimen. One is with a steroid, second is an antiproliferative agent, mycophenolate is a preferred one, other one is azathioprine. Then you have calcineurin inhibitors, that is preferred again is tacrolimus or a cyclosporine. Steroid, you start in the intraoperative period and you try to taper it off, again different institutional protocols, and then you convert that into a tablet wise. So on there, mycophenolate and tacrolimus, you start giving the patient right before you take the patient to the further surgery there, like described by the previous speaker there. And post-operatively, you continue these drugs. When it comes to the calcineurin inhibitors, what is important is you keep a monitoring of the drug levels in this patient at regular intervals and have you have to see that you have achieved the target levels of this. The main issue with calcineurin inhibitors is the nephrotoxicity secondary to them, especially in the post-operative period. You may or may not be able to start these drugs in the patients for the first few days. Along with that, they have drug interactions with a lot of drugs, so that you're always mindful of that. So to sum up, you always titrate your immunosuppression therapy in every patient, individualize it, targeting your drug levels, looking at different parameters like your renal parameters, what is the infection status, how is the patient status, what are the preoperative immunological profile of this patient. Based on all this, you titrate your immunosuppression therapy. So let's look at with that, after looking at the basic care, let us look at what are the complications you see commonly in the post-operative period. So as described before, the most common thing what you see is the primary graft dysfunction. This can present right from the theater. Very simply, like when we expect the donor heart to work normally, a donor heart which you have accepted, thinking it's a normal function there. If it doesn't work in the expected way in the post-operative period, it is called a graft dysfunction. And if there is a clear cause for the graft dysfunction, then it is called a secondary graft dysfunction. If there is no evident cause, then it is called a primary graft dysfunction. The primary graft dysfunction is because of multiple reasons. And as you see, this can be an isolated left ventricular primary graft dysfunction, or a right ventricular primary graft dysfunction, or a combination of both. As you see, the cardiac function in all these videos is suboptimal compared to what it was in the donor heart when it was accepted. The standard criteria from the ISHLT defines the PGD into PGD-LV and the PGD-RV. Again, the PGD-LV is divided further into mild, moderate, and severe, whereas the PGD-RV, there is no further subclassification of this. What is important to understand from this classification of this table is all these patients, when we are monitoring them in post-operative period, you need to keep a close watch on all these parameters. You need to look at a close watch on your cardiac output, both by direct measurement from one of the cardiac output monitor, preferably the PA catheter base, or your indirect measures like seeing your pulse, seeing your lactate level, seeing your mixed venous oxygen, seeing what is the response to the diuresis in this particular patient, is urine output adequate. So you keep a close watch on this. You keep a close watch on the filling pressures, the right atrial pressure and the wedge pressure there. And also you keep a close watch on echocardiography. So based on this, the PGD-LV can be mild if it is only like a less than 40% EF with requiring lesser inotropes, or it can be moderate if you require a balloon or a higher inotropes. If you require any mechanical circulatory support other than balloon, then that is classified as a severe PGD-LV. Whereas it comes to the right ventricle, again, as we see here, there are no echocardiographic parameters that is included here. That is because it is difficult to clearly define what are the abnormal values of the RV based upon your echocardiography. So this is based upon primarily upon your hemodynamic variables. When you have a right atrial pressure more than 15 with a decreased cardiac index, that is when you call it a PGD-RV. With a normal left ventricular function, that is when you call it a PGD-RV. So whatever it is, PGD-RV or PGD-LV, you keep a close watch on the cardiac output, direct monitoring, and all the other parameters, urine, lactates, and pulse, all these things. You start escalating your therapies, that inotropes and inodilators. If that's working, well and good. If that is not working, if the issue is persisting, if the patient is going to low cardiac output, you escalate your mechanical circulatory support. IABP is the first one you consider. Or if that doesn't work, if you're talking strictly in the post-operative care, ECMO is your therapy of choice. VAD is also an option for this, but for that, the patient has to be in the OT. You have to shift back and put that. Rather, in the post-operative period, a better choice is an ECMO for this patient. The second common complication, what you see in this patient, is an isolated right ventricular dysfunction. This can be because of multiple reasons. This can be the PGD-RV, like what we discussed before. This can be because of the pulmonary hypertension, or this can be when you see a donor mismatch or a prolonged ischemic time. A lot of causes lead to the right ventricular dysfunction. Typically, you see a elevated CVP with a borderline or a low cardiac output or cardiac index in this patient. The timeline again varies. This can present as late as second or third day post-transplant and then persist up to say 2 weeks or even longer than that. But in good amount of cases, it settles down. As you see in this echo, a transthoracic echo, the RA-RV is dilated and there is an RV dysfunction in this patient. The primary way of managing these cases is optimizing your preload. You try to minimize your fluid. If there are any secondary factors like a high PA pressure, you try to bring them down. Very important, you always make sure that you maintain an adequate mean arterial pressure in all these patients, and you titrate your inotropes and inodilators so that you bring down the CVP and maintain your adequate cardiac output in this patient. Diuretics, if that doesn't work, renal replacement therapy. And if none of this works, then obviously you have to consider an ECMO, or if you have to do an RVAD, you have to take back to the theater and put RVAD in this patient. Atrial septostomy, like Julia sir said, is not a standard practice across the world, but that is something that is practiced in our institute, where the shunt across the atrial septostomy or the saturation of the patient will give you a rough idea how is the RA-RV in this patient, how is the patient going to fare or responding to your different therapies there. So other issue, what you see is a pulmonary hypertension. As a part of your preoperative workup, you evaluate the patient, you make sure the patient is not a case with a high PVR, but still because of the time gap between your evaluation and accepting a donor in this patient, quite common, you see that the peer pressure, what you find on table are different from what you have seen in the preoperative period. In these cases where the TPG is high or the peer pressures are high, you electively ventilate these patients. Usually for 2 days or 3 days, we ventilate this patient, use nitric oxide, use ionodilators, and use the pulmonary PD inhibitors and all. Wait till the peer pressure settles down, and then plan the extubation in this. In these patients, like we discussed before, managing the right ventricular or the cardiac output is of paramount importance. So if you look at any of this, we are looking at a PGD-LV or a PGD-RV or an isolated RV dysfunction or a pulmonary hypertension. When you're not able to manage by your conventional measures, that's where you go into the mechanical circulatory support. Or it can as well happen that a patient had all these issues in the intraoperative period. Patient has been put on an ECMO or patient has been put on VAD, and then he has been shifted to the ICU for management there. So what is important is, or what we need to know is, the chances of recovery when we use an MCS in the post-transplant period will always good. So what is very important there is going for an early support rather than a delayed support. There has been enough evidence in the literature that says that when you go for a crashed MCS option, the outcomes are much poorer. So ideally, you identify in the OT and try to put them in the OT. If not, if the problem develops later, like PGD can happen up to 24 hours. What you see in the theater may not be the same. After 6 hours, 12 hours, the cardiac function can deteriorate. So if you have a situation like that, post-operatively, you institute it early. So just to quote a couple of papers, this first one is where they have clearly shown that there is an excellent chance of myocardial recovery and a decrease in mortality when you use an VA ECMO for patients who are having a PGD. The second paper, it is quite interesting. This is from a single institute. What they have done is they analyze the data about the usage of ECMO for the PGD in the post-operative period. So what they found was before 2017, the outcome or the chances of successful weaning of ECMO was only 61%, whereas after 2017, when they changed the way they practiced, they were able to come off ECMO in 100% of the cases. That means every patient of PGD post-heart transplant, they put on ECMO, they are able to wean it off. So what changes they made? The first and most important thing is the objective criteria. So that clearly tells us to identify based upon the objective criteria, have clearly set limits at what point you're going to say medical therapy is not going to work, we're going to offer mechanical circulatory support. And second is early ECMO if the patient needs. So that's the most important change what they made after 2017 that resulted in a 100% successful weaning from the ECMO. And second is having a partial ECMO flows. Then they kept the chest closed. So these simple things will help us in choosing the MCS and coming out of it successfully there. The other complication, what you see in a post-transplant period is the graft rejection. This can be a cell-mediated or an antibody-mediated rejection. The hyperacute rejection, you don't see that commonly now, or it is very rare. So the incidence is roughly up to 30% of the cases, of which around 5 to 10% of them can have a hemodynamically significant rejection, and it can contribute roughly to 1 to 3% mortality of this. So how do we identify? Your identification is clinical. That is, if your patient is having an unexplained low cardiac output or an unexplained increase in filling pressures, or if the echocardiography points out or shows that there is a decrease in the graft function in the postoperative period, you always suspect rejection. The main way of confirming is by the endomyocardial biopsy. The standard ISHLT guidelines says that every week we should do a biopsy, but there have been institutional modifications to this, like we do once in 1 week or 10 days. If that is negative, we won't subsequently repeat the biopsy there. There are certain blood tests like single antigen bead which help us in identifying antibody-mediated rejection. But if we talk of pure immediate post-operative period, the other things like cell-free DNA and all are not useful, are usually up to 45 to 50 days in the post-operative period. So once we do the biopsy, there are clear gradings from the ISHLT, both for the cell-mediated and antibody-mediated rejection, to see what is the grade of rejection, 0, 1, 2, 3. The more the number, the worse the degree of rejection. So whenever we see a patient who is having a rejection, it is either one of this. You have picked it up on surveillance. Your echo has picked it up, or your biopsy has picked it up. Or a second scenario is you have a new onset cardiac dysfunction. Your patient is having a suddenly ventricular dysfunction. Then that's how you picked up the patient is having a rejection there. In either of these scenarios, you get the full information. If you have just picked it up on a new onset cardiac dysfunction, get a biopsy done. Start the treatment, get a biopsy done. On the other side, if you have just picked it up only on biopsy, get a graft evaluation, that is, do a full echocardiography in this and look at the filling pressures. Based on this, you titrate your therapy in this patient. But grossly, the main principles or goals in the management of any rejection is this. First, you ensure that your patient is hemodynamically stable. Some of them may require inotropes, you start it, diuretics, start it. If the patient is so sick that needs a mechanical circulatory support, quickly go and put the patient on MCS in this patient. Then along with that, you also look at rejection specific management. What is rejection specific management? For a cell mediated rejection, the mainstay of therapy are pulse steroids, usually you give 250 mg BD, and antithymocyte globulin. So to have a practical approach, if your patient is hemodynamically unstable, or if the patient is having a graft dysfunction there, irrespective of what the degree of the rejection in the biopsy finding, even it is 1 hour or 2 hour or 3 hour, if there is a decrease in the EF or there is a graft dysfunction, you go for both. You do the pulse steroids and you give the ATG for the patient. On the other side, if the graft function is normal and the patient is having only a biopsy proven rejection, then based upon the rejection, if it is a 3R, again you give a pulse steroids. If it is a 2R, you just increase the dose of steroids and try to manage with it. If it is 1R, you just try to optimize your immunosuppression therapy there. Similarly, for antibody-mediated rejection, the mainstay of management are this: steroids, plasmapheresis, IV immunoglobulin, antithymocyte globulin if required, and rituximab. So a practical way of approaching this is as so shown in the diagram. The one on the right side shows if the patient is clinically stable, you just give a pulse steroids followed by plasmapheresis and then give IVIG at the end of this. If the patient is unstable, then along with this, you add an ATG to this. If required, acilizumab. And subsequent to all this, you give the patient a rituximab, that is to decrease the future production of antibiotics and antibodies. So a lot of some of these patients can have refractory rejections. That's when you consider the other therapies, that is bortezomib or daratumumab, all these things you consider if the patient is having a refractory rejection episodes. So whatever the category of rejection, cell mediated or antibody mediated, what is important is this: you first optimize the immunosuppression for all these patients. You see whether you have achieved therapeutic levels or not. You see whether you need to modify your drugs, whether that can lead to better, like myfortic and tacrolimus combination is shown to have better outcomes. You keep a close watch on response to therapy. Repeat a biopsy after 2 to 4 weeks. Look for drug-induced complications, what you're giving. Infection flaring up is quite common when you're handling the rejection episode. So you keep a close watch on that. And you keep an enhanced surveillance for these patients. Even after you treat everything, there's always a risk of having a second episode. So you keep an enhanced surveillance for rejection. Then you handle the cardiac function. That is, they can have in that time, they can have arrhythmias, they can have a decreased cardiac function, which can settle, which may not settle. So you handle the cardiac function. So this is how you approach and manage rejection in this patient. Apart from this, the other common complication, what you see, especially in Indian scenarios, infections. Strict infection control and early delaying is very important in this patient. This is one of the common contributor for the mortality and morbidity, a variety of risk factors. The patients are hospitalized preoperatively, they're very frail, we're immunosuppressing them, they're going to stay in ICU, all these contribute to this. Bacterial infection are by far still the most common ones, but what we need to know is, like, not every elevated WBC count or not every elevated procalcitonin value means an infection. There are a lot of non-infective causes, like immediately post-transplant, you see elevated WBC, elevated procalcitonin. Similarly, when there is a rejection, you see an elevated WBC counts. So not every elevated and WBC count or procalcitonin means an infection in this case. Along with a bacterial, what you commonly treat in this is prophylaxis for the cytomegalovirus. That depends upon what is the status of both the donor and recipient. If the recipient is negative and the donor is positive, you put them on ganciclovir for 3 to 6 months. And if the recipient is positive, you put them roughly for 3 months. So whenever you treat them for any reason, like you do give them pulse steroids, or you have a rejection episode, or a patient has a lymphopenia, there's always a risk of CMV flaring up. You keep a close watch on that. You give Septron prophylaxis for all these patients, say 1 year or maybe lifetime for pneumocystis prophylaxis. Fungal infections are also common, especially the ones who are having MCS or prolonged illness, open just this category of patients have a risk of fungal infections. The other issues what you face them is the bleeding that has been discussed by the previous speaker, but still patients who are on anticoagulation, especially if your patient has been shifted from the theater with ongoing ECMO or a VAT support, that category of the patients, or who are having a preoperative significant RV failure, these category of patients is always a risk of bleeding. You guide it with your viscoelastic guided management there. What is important is identifying the tamponade in the immediate post-operative period if it happens. As I said, the transthoracic images may not be great in this patient. So whenever you have a clinical doubt, you put a TE probe and see, or involve the surgeon to discuss the need of re-exploration when you're suspecting a tamponade in this case. The other issue, or the one which troubles you, is a renal dysfunction, which you see in the post-operative period, a variety of causes. Cardiorenal in the preoperative period, right ventricular dysfunction, drugs, sepsis, all this contributed. You have to balance it with multiple things, the requirement of your calcineurin inhibitors, the requirement of diuretics, the optimizing the RV failure in these patients in the post-operative period. All this you need to balance it out in post-operative period. Certain amount of them will require a renal replacement therapy, whether it is a CRRT or intermittent dialysis. So you need to be well versed in handling that. Another important thing when you see these patients is the rehabilitation. Quite a few of them will be very sick with prolonged hospital stay, barely out of bed, with severe muscle wasting in the preoperative, or a post-operative sick course like requiring a mechanical circulatory support makes them to have a critical illness neurobiopathy. So involving a rehabilitation team taking care of nutrition and physiotherapy is extremely important in bringing them back to the normal life. To sum up, this is what it is. You need to keep a full hemodynamic data monitoring, cardiac output, PVR, SVR in this patient, and have a low threshold for doing echo. You may have done only a little while back, but again, if you have it out, always put a probe and see. If images are not clear, put a TE probe there. These are the main complications: PGD, infection, bleeding, and rejection. The immunosuppression has to be titrated for every patient individually. If you require MCS, it's always early than late. Early is always has better outcome. A good critical care makes a lot of difference in these patients. Thank you.
Thank you, Dr. Mulli. Over to Dr. Mullidhar for the remaining proceeding of the webinar.
Thank you. Thank you so much. All the four speakers have done very well. Nandita, Julius, Raghu, and Murali, they have dealt with their respective topics in a very succinct and clear manner. Thank you so much. Now, the subject is open for discussion, and I would like to invite comments from Dr. Chintan and Sanjay before we actually go into the chat box. Poonam, if you want to say anything, please feel free.
Yes, I just have two comments. One for Dr. Raghu. What would you prefer, the TAPSE or the S prime for the RV dysfunction in the post-transplant period or peri-transplant period?
Because no, actually, ma'am, the more sensitive is fractional area change. Is more, I feel that is more important. And the newer parameter is IVA, isovolumic acceleration. One thing, this one is, sir, you look at the time, S prime divided by the time taken to reach the peak of S prime. If you divide, normally you should get about 1.2 to 1.8 meters per second. That is volume independent factor. If you try to get that, I think FAC and IVA are the best options, I feel, ma'am. TAPSE and all doesn't, because the pericardium is open, I think TAPSE and all will not be a suitable indicator for RV dysfunction.
I do agree with that. May I request all the panelists?
I personally feel S prime tricuspid valve, whether at the medial or the lateral annulus, it provides information actually regarding the velocity of the entire RV longitudinal contraction. Since we are in an era of RV strain, IVA as well as S prime are both load independent parameters. And because they are load independent, they have become better than TAPSE or even fractional area change. And these should be the dynamic real-time parameters to be studied for right heart function today. Of course, fractional area change less than 35%, you mentioned well. And for Murli, Dr. Mullidhar, I'll just take a minute more.
Yes,
A lovely presentation, Dr. Murli. And I just wanted to add a comment. We just had a post-cardiac transplant patient readmitted after 3 months. And the patient was not doing well, very frail on polypharmacy, kind of bleeding from the nose on and off, all viscoelastic tests normal. Patient had been on prolonged warfarin for some time post-op. At that time, we were all giving warfarin. Today, it's an era of apixaban or rivaroxaban if you want to continue the anticoagulant in the post-op period for some reason or the other, depending on the individual patient coming. Now, this patient grew first Candida gibraltar, and then while we were treating to the sensitivity of the fungal microbiome of Candida, which was voriconazole, all the azoles, as well as liposomal amphotericin B, this patient also grew with lesions in the PET scan only, showing in the chest histoplasmosis. So, patients who are on prolonged antibiotics, immunosuppressed, like this in the post-op period, are not only suffering from viral diseases but also a lot of fungal diseases. And treating these fungal diseases is a big, big nightmare for any intensivist. Multiple fungal microbiome culture sensitivity takes very long, much longer than the normal bacterial culture sensitivity. And when it came, we were surprised. It was just sensitive to itraconazole. So patient went home after a prolonged time in the ICU, but very frail, rehabilitation not possible, very difficult to give nutrition. So we should be very, very aware that we are going to be in an era of having patients with a lot of viral and fungal infections along with uh, as major complications beyond rejection and PGD. Thank you. Thank you. Lovely to listen to all four. It was excellent. Thank you, Dr. Muralidhar.
Thank you. Thank you, Dr. Poonam, for your input. Of course, fungal infections are a serious risk after transplantation because of the immunosuppression, and most common organisms are Candida and Aspergillus. And you have also given your thank you so much. And Chintan, do you want to say anything?
Yes, so good evening, everyone. So preoperatively in few patients when PVR is high, like more than 4 or more than 5 high PVRI, and we give vasodilatry challenge and everything, and still PVR is remain high. In few of such patients, we have started home milrinone for 1 to 3 months, and after 1 to 3 months, when transurgical we found PA pressure has gone down, we have again done the right heart cath, and many of few those patients have now the acceptable criteria. So home milrinone should be in our armamentarium when we are doing the vasodilatry or reversible therapy for the high PVR. So that is one comment. And I just want to ask Dr. Nanita, what immunology workup you would like to do for this patient?
Good evening, sir. With regards to immunology, the HLA antibodies, they have to be screened because these patients would have been requiring any kind of blood or blood products. So that further increases their sensitivity with regards to with regards to any kind of foreign object or any kind of foreign material in their body. And apart from that, and repeated screenings have to be done, sir, as per the clinical status every 3 to 6 months, depending upon how the patient has been receiving any kind of external transfusion or anything of additional products, sir.
So you would like to do the panel react antibodies or any other test also you do for the screening?
Sorry, can you repeat the
question? So you do panel reactive antibodies for that?
Yes, sir. The infectious diseases team is also taken in beforehand, and they usually help in with the screening of the HLA and the infectious diseases as well.
Dr. Julius, do you want to add to anything on that?
I wouldn't get into a talk with Chintan on immunology. He's probably the best known immunologist on the group. So just that we don't do PRA because the commercially available reagent which the labs use come from the US. So if you have a PRA of 80%, it means that your transplant recipient may be having antigens against 80% of US nationals. It doesn't mean much to us. So we rely more on doing a single antigen bead and figuring out what are the exact anti-HLA antibodies which are present in the given recipient. And at the time of transplant, we just do a CDC cross match, and it varies. We generally won't be able to do a single antigen based or um, solid state cross matches at that time. Because the samples generally go to another lab and they are the ones to do it centrally. So whatever they do, we generally accept that in terms of the HLA question. And in preoperative evaluation, I think from the surgeon's perspective, you probably have to also look at the chest wall deformities, because sometimes the anterior posterior diameter, if you have a straight spine and a straight sternum, will be so small that you will not be able to fit in a donor heart there. The recipient's heart was meant to sit there, so that will somehow squeeze itself and sit there. But when you put in a normal sized heart, which is used to a certain amount of space there, you just won't be able to squeeze it in there. I would take it as an absolute contraindication. So again, you should always be very, very wary about things which you are not going to correct during the operation, like the amount of collaterals which are there, and in order to tailor the perfusion accordingly, and you may expect complications related to the collaterals later. All these and certainly kyphoscoliosis and all of that, you have to assess all the deformities quite well. Just to add to Nandita's pre-op lot. And again, we tend to stop the Vimada as soon as we list a patient for transplant, because that is one of the leading causes for having vasoplegia at the end of the operation. So vasoplegia is a very difficult thing to manage. And if you look at the indications for Vimada, it stops at stage 3 heart failure. It is not meant for stage 4 heart failure. I mean, stage D heart failure, it is not recommended. So by definition, those who are listed for transplant are in stage D. So I tend to stop that.
Thank you. Thank you. Dr. Sanjay, do you want to say anything before we go to the chat box?
Yes, I just had one question or a comment for Dr. Murali Krishna. In your presentation, you had put up a slide where you quoted a particular article where a particular group had reviewed their practices and with regards to mechanical support ECMO in PGD. And they had come up with a set of changes, and one of them was running partial ECMO flows with the chest closed. So what did they attribute the success of that particular change to in their cohort?
Thank you. You're specifically asking only about partial ECMO flows, or you're asking generally about that paper?
No, just that particular article. What did they attribute it to? Because it kind of sounds counterproductive to have ECMO and not run it on full flow, especially when you're having organ dysfunction. And they
when you say
their...
Okay. So when you say partial, I mean, you're not, suppose if you just put a ECMO for an RV dysfunction, like the patient may still be good with your 2.5 liters cardiac support there at that point. Okay, you did not give the full cardiac index of whatever required 4.5 liters in that particular patient. So even if the heart is working in that patient and you support just with 2.5 liters in that particular patient, that still may with a native heart cardiac output, plus this may still work out to be an adequate cardiac output for that patient. I think that's what they were talking, and that's the usually practice. What I mean is, once you put on ECMO, you just don't increase the flows to full flow unless you have to handle some metabolic deficits there. You try to still keep a reasonable filling pressures, let the heart eject out. You try CP of 8 to 10 rather than keeping the CP totally 0.1 in that patient there.
This particular change, did they do it on peripheral ECMO or did they do it on central ECMO or a combination of both?
So they were on peripheral ECMO, but what they did was they converted them to subclavian ECMOs in some patients and then closed the chest.
And was it anyway attributed to lack of adequacy of drainage and thereby not getting full flow?
No,
to be one of their
that.
causes of running a partial flow ECMO?
No, not that.
Right. Okay. Thank you, doctor. Thank you.
Thank you.
Thank you. Thank you so much. I'm just opening the chat box. I think some of the questions have already been answered. The normal heart in situs inversus. Dr. Julius wants to show the video. Are we okay with that? Dr. Poonam, are you there?
Not video, just slides.
Dr. Poonam,
Yes, sir. If
we
we have
would like to
time.
see the slides of these
Yes,
sites.
yes. Let's
So,
go ahead. He has 4, 5 slides. Yeah.
sure. Dr. Julius, please carry
Are
on.
you seeing my screen?
Yes, we can.
Yes.
So when you are doing the aorta and PA anastomosis, it is not necessary that you have to put it exactly where it was before. You could make another place to put the PA anastomosis when you're doing it that way. This is an example of how you can see the PA is going across the aorta under it. So when you reconstruct the aorta, it'll be crisscrossing. And for the specific question on dextrocardia, you would be opening the pleura so the heart will stick into that side, and you open the pericardium and above the phrenic, and the heart will stick there. And this space you have to close because otherwise it will attract a lot of fluid. In situs inversus, there are a few techniques which can be done. One is to redirect the flows like that and do a biatrial anastomosis. And the other technique is to bring everything back to the midline. So you have the aorta there, PA, you close the original hole and make this there. LA is not too much of a problem. Here, if you need further extension, you can use atrial tissue to extend that. For the LSVC, you would use the donor innominate vein. So it is not as difficult as it looks when you actually do it. And there is another very complex Rubik's Cube kind of technique that is described. I've never really understood this, so please don't ask me anything about that. So I hope this answers your question.
Thank you. Thank you so much. The next question is about muscle relaxant and brain dead donor. That has been answered. It's better to give the relaxant to avoid spinal reflexes.
Yeah.
It's answered.
The reason for that is suddenly, if you're not given relaxant, the patient just lifts his hand like that.
Yes.
Then everybody is confused if he's brain dead or if he's not.
Absolutely.
It causes a lot of issue there.
Yes.
Because these Lazarus movements can be quite extensive. It's not just a flicker. The whole limb can move.
Can be a powerful movement. Yes. Next one is about preoperative donor stabilization. Dr. Ratan wants to know. Ratan, can you please unmute and ask your question directly to the panelist?
I think Dr. Murali Krishna will be the best. He's done a lot of that to answer that.
Which aspect, Dr. Ratan, you want the preoperative donor stabilization to be tackled? Murali, would you like to take that question in a quick manner?
Sir, donor stabilization, like a lot of times what we see is a decrease in the cardiac function of the donor. Sir. When we assess them, the cardiac function comes down. That can be many reasons. Your brain death pathophysiology can be there. But there are some reversible or modifiable factors there. One of the common thing what we see is an afterload mismatch. A lot of them, they just increase the pressures and target a much higher mean arterial pressures. Probably the other teams, other organ perfusion teams may be happy with that, renal team and all, but that causes a lot of harm to the heart especially. And when we typically assess this organ, you see a decreased function. Along with that, you see a mitral regurgitation in this patient. So sometimes it will be even a moderate MR, but a normal mitral valve. That is purely because of afterload mismatch. You start working on them, you adequately fill them, you try to bring down the afterload, cut down your constrictors. If required, start a small dose of inotrope and then inotrope or inodilator and see the response gradually. We can give the hormone therapy in them. That's again now debatable, but hormone therapy, if it is not given, we can give that. We keep a close watch, and then it takes few hours, but you'll be able to stabilize them.
Murli, can I ask you a comment here?
Madam.
Recently, frailty as a donor is a relative contraindication. You don't want donors who are very frail. At the same times, we do take some recipients besides doing the immunological matching, the blood group, and the height and size. We do take, recipients who are frail. Now, that's not a contraindication, not even a relative one. How do you see this mismatch in the nutritional status or the frailty status? Many diabetics on polypharmacy, maybe around 60 years or 55 years, not a contraindication age wise, are being taken up as recipients and they're frail. So, how do you see them? How do you see this reversible risk factor? Frailty is a reversible risk factor with good nutrition. You may delist them that time, but maybe you are listing them again. But how do you see it? Because this is a very upcoming situation with new definitions of frailty and new guidelines on frailty coming up in recent times. And we're going to see such patients come up with comorbidities who are frail. Have you seen it in your practice? We're seeing it. And it's vexing. You take on.
Hello. Yes, ma'am. Now it is audible again. Yes.
Yes, Murali, would you like to answer that?
Frailty, yes, it's assessed preoperatively, and that's obviously a multidisciplinary team assessment that you involve the rehabilitation team, nutritionist, and the physiotherapy team. Everyone, you assess it, and then you take it. By far, declining cases because of a very bad or very poor frailty, it's very rare, ma'am. Most of them you will be able to manage. The question is how we can work on them when they are in the waiting period and how long that work needs to go on. That obviously has to be aggressive. Nutrition to any extent, a lot of them, if we just leave them only for the oral feeds, will have a very poor oral intake. If we daily talk to the nutritionist when they're in the ward, what percentage of intake or what percent of proteins they have met, it is barely 20-30%. Typically you start with that supplemental drinks, and if that doesn't work on within 2 days or three, very low threshold to put a Ryle's tube and start feeding them. There'll be a lot of patients won't like it, but still you start counseling them. See, 2 days we'll wait and see if you're improving in your intake there, that's well and good. But every day you talk to them, say I've met only 20% of your dietary intake. If you tomorrow you get better, that's okay. If not, then finally we have to do that. A lot of them comes to that acceptance when you go in a stepwise way. Again, you see some category of them, especially RV failure. Along with this, you have a very severe gastritis. Whatever you give, they won't be able to take anything. They're TPN, but a very small fraction of them TPN. Most of them with the enteral nutrition and supplementing them orally, encouraging them to take whatever they can or whatever they want within that permitted limits of fluid intake is what works. Similarly, physiotherapy. That also makes a lot of difference. Your main problem comes is in that ICU patients who are preoperatively long bedbound, who are preoperative on mechanical circulatory support for longer time. There also you try to work and do the rehabilitation in a maximum way, whatever you can, to see that they are in the path.
So the new British guidelines come out with prehabilitation, a lot of emphasis on prehabilitation of these recipients. Then these,
yes, ma'am. It makes a lot of difference.
And they delist the patients then, and then they bring them back to the next donor list in 3 weeks' time. It was something very surprising, but I read it, and we did something similar to our recent one. Also, getting a donor heart is not easy, but whenever you get it, you've got to see the recipient's nourishing status as well as the ability to walk. Otherwise, you have a bet gone for a long time in the post-op. But thanks for this.
We had one patient whose BMI was 17.5, and he underwent transplant, and within like some 2 weeks he developed lung infection, and ultimately he succumbed to death. So I think this frailty and low BMI and cardiac tachycardia is really very important. We have to. So if they are on the wait list, and if you get the heart, and still if they are not nutritionally well built up, I think we should wait and don't just jump to the transplant.
Totally agree, because when I read the guidelines and we did the delisting, it was something new. It is a relative contraindication. Donor, it is a complete contraindication. But even delisting them for the recipient, because they will be in a prolonged state, even worsened in the post-op. Thanks for that.
If you look at the guidelines from ISHLT in the 2016 guidelines, they have said that you have to take frailty into account. They have not said that that is a contraindication. And in the recent guideline also, that is not changed. So there is a study which has shown a difference between the disease, this particular disease-induced frailty, that is heart failure-induced frailty versus frailty otherwise. If you are treating patients with heart failure-induced frailty with an LVAD, their frailty improves very quickly after putting on an LVAD. But that study has not been shown in transplants. So if you think it is a patient whose frailty is due to heart failure, I don't think denying transplant is a good thing. And this has been there in the guidelines for a long time. And the usual, I think, the first Nandita had spoken about the frailty index, which is purported by Linda Fried. Linda Fried has put these 5 things: slow walking speed, etc. There are 5 things which you can easily assess. There is another Montreal cognitive testing which is also used, but that has got 120 parameters. Therefore, nobody actually uses it. So generally, this is what everybody uses, and we assess all our patients for frailty, and objectively, not just end of the bed visual assessment. You do an objective assessment. You do the grip strength with a meter. All of that we do. Only recently we had to postpone one patient for prehabilitation, and after he gained a few kilos, and once he showed he's motivated, then we transplanted him. I mean, he's still
We
in
did
and
the
out of the
same.
hospital. And I've lost one patient purely from frailty. And I've not seen any literature on donor frailty, to tell you the truth.
Next patient transplant. Yeah.
Thank
No,
you.
there is surgery, knee surgery, pre-op, peri-op and pre-op, not donor. Donors, they have mentioned it is a relative contraindication. Transforming the frailty pathways, the article from NHS.
Yeah, I mean, the ISHLT guidelines are what we normally take as the standard. Other than if you're interested in the frailty part, there is a lady called Sunitha Jha. She works in St. Vincent's in Sydney. She's done a lot of publication on frailty. She's done a tremendous amount of work on frailty.
Look up. Thank you. Thank you.
Thank you. Thank you. The next question is for Dr. Murali. I think it refers to Murali Krishna. I want to clarify your protocol. Is ATG induction administered universally to all patients or reserved specifically for CDC cross-match positive recipients?
ATG induction is not something that is for all patients. Our standard is to use the basiliximab there. Only if you have a situation where you don't have basiliximab available, that was there in between for a period when the drug was not available. In that situation only, like again, we take it on case by case basis. Some of them we go only with steroids, like giving a good dose steroids, and where you are sure that you can start the calcineurins within few days post-operatively. They still go with steroids, calcineurin, and myfortic only. But if you are not able to do this, like steroids you still give, but you're concerned about the chances of rejection, you're also concerned about the kidney in that patient, there we think of giving the ATG.
Deep, I don't think you should go against a CDC cross-match positive and do a transplant. That is inviting trouble. It may be anti-HLA antibodies, it may be non-HLA antibodies, but once you have a positive CDC cross-match, and if it develops a hyperacute rejection, you'll have no feet to stand on. So we must not take a CDC positive patient for a transplant. And we have stopped using ATG or basiliximab for induction. We just give preoperative tacrolimus, MMF, and steroid.
I saw
We too have stopped. We too have stopped recently, about 4 months back.
Yeah.
Only tacrolimus and steroid.
So you don't use basiliximab also, sir?
No, we don't use basiliximab. I think we stopped using it when it was not available. And we didn't want to use, we did not want to use the ATG because that's carpet bombing. And they come back with some infection or the other. A lot of our patients go back to poor surroundings, which is not nice.
That's used predominantly in 2-3 scenarios, sir. One, as I said, like where we can give basiliximab and post-operatively you're taking a longer time for renal. Second is the refractory rejections.
Yeah.
Okay, if you're not able to handle.
What I said is we don't go give induction routinely.
Routinely, yes, sir.
Yeah. If there is a specific indication, then yes. Or if there is a lot of preoperative antibodies and all that, we can use.
Yes, sir.
Otherwise,
And I saw in that anesthesia for transplant slide that MMF is given IV.
Yeah, I think no, we give oral.
Okay, sir.
I noticed that. See, what we do is we use the syrup MMF in the first few days while the patient is intubated, because you're not supposed to crush the MMF tablets. Therefore, we use syrup. Pre-op, we give a tablet. Then till the extubation, we use syrup. And then after that, we switch back to oral.
Thank you. Thank you for that input. The next question is, how frequently do we need to cell-free DNA? How frequently we need to cell-free DNA? Do you want to
50
take
days
that?
roughly post-operatively, up to 50 days cell-free DNA. There's no recommended role for it. It's only subsequently where it is. And if we're talking purely in the context of post-operative management, that's why I didn't include that in my talk.
Right.
I think we start doing a little earlier than that.
Sir.
Yeah.
4 weeks or 6 weeks.
Yeah, 2 to 4 weeks we start doing. And
that will be only the baseline value, baseline.
Yeah, that's right.
Not as a
no, not as a
like
surveillance. That when we do
surveillance,
biopsy
but
also.
subsequent use kind of.
Yeah. We do biopsy as well. But one good thing about the cell-free DNA is that that starts picking up rejection even before the biopsy becomes positive. So it can be way ahead of the biopsy in the surveillance pickup. Chintan, you want to add anything?
No, sir, we don't have any experience of cell-free DNA.
Okay.
Right. The next question
again has to be read. So that DDCF DNA, you have to look at the fraction of it, look at the clinical reasons. If it is elevated, it can be falsely high, it can be falsely low, both the ways. You have to look at the scenario and see. But in the immediate post-operative, if you're looking at whether it has a role, it doesn't have any role.
Yeah.
It is
See, it's again a percentage.
By many other factors.
It's again a percentage.
Yes,
so if your recipient is having a lot of cell damage for some other reason, some infection in the lung or something like that, then the recipient's cell-free DNA will go up. And even though the actual numbers in the donor-derived cell-free DNA is high, as a percentage of the total, it may look low.
Falsely low.
Falsely low, yeah.
Thank you.
So all that has to be taken into account when you're doing this.
Sure. Regarding tuberculosis, the answer is already given here. Patients with active tuberculosis are generally contraindicated for heart transplant. I think that's a reasonable reply. Next question is about what may be the reason for better survival with partial ECMO flow versus placing the patient on full flow.
Tuberculosis, just to add a comment like that, I mean, active is out of question, sir. But we do check for that interferon, the old latent TB. And if the patient is having a positive there, you put them on isoniazid prophylaxis post-operatively.
Role of endocardial biopsy post-transplant.
It's question role of.
And I think
That's still considered gold standard.
Yes.
It's mentioned.
And we do.
Mentioned already.
And different institutes have different protocols for that. But I think most of the institutes do 4 biopsies in 1 year. We do it 1 month, 3 months, 6 months, and 1 year.
Sure.
So different institutes, different protocols. But at least I think 4 to 5 biopsies per year is, I think,
4 biopsies.
Follow.
4 biopsies a year. We do 1 every 3 months. While the patient is with us after 1.
We have switched over to cell-free DNA for the later surveillance.
Right.
We also do only 1 or 2, not
that's
not
it.
4 kind of thing. Only
First
1
week or 10 days, and then once more. And if that is not showing anything, we don't really do a biopsy unless if cell-free DNA is showing a problem, or if there's a clinical reason, then we do a biopsy.
We do twice after the surgery, and then when on follow-up every 3 months. And I think they're becoming rarer.
And if you go by the recommendations of the US, you need a weekly biopsy initially, then bi-weekly, then every month for the whole
12 in first year, I think. So
Yeah.
12 or 14 in
So
first year.
it'll be more than 12. So if that much it'll be too expensive to manage. Biopsies are expensive.
And what is your protocol, sir? Coronary angiography protocol?
We do annually.
Is there any
A lot of
protocol
times
for that?
No, we just do CT. Usually
CT
it's not
coronary angio.
CT coronary angiogram is what we generally do.
So
And
how frequently, sir? What's your
once a year.
protocol?
See, we will do one baseline if it's
Once.
a older donor particularly. We'll do one baseline if we're not able to get a preoperative coronary angiogram. And then if that is okay, then once a year. And that sort of continues indefinitely because not everybody comes once a year for the follow-up. Now, I think the longest we have is 15 years or so. They will need IVUS and all that as time goes by after 5 years. And because general angiogram alone may not pick up the graft vasculopathy. It's best to do an IVUS.
Sure. The next.
Dr. What is your protocol for angiography?
Angiography, donor side, very small number of cases will be able to do it before. Assessment is still the basic rough way. Surgeon sees the plaques and depending upon the assessment, based on that they go. When it comes to the recipient post-transplant, we take, like sir said, the donor age into consideration. When they usually come for that 1 year follow-up biopsy, angiogram is done in most of the cases. If that angio is normal, then subsequently most of them will be like CFDNA and DSA follow-up only. If there is for any reason they're going for a biopsy, along with that, most of the time we do that. But long-term follow-up patients, the angio plus IVUS to CCAV, that's done.
We do 1 year angiography first, baseline of 1 year, and then every second year we do angiography.
Fair enough. I think everybody has got these.
Different,
We do yearly to
different
CT
protocols.
angio yearly.
If you have detected coronary artery disease, then you change the immunosuppression and use an mTOR inhibitor in addition.
Yes.
Thank you. The next question is about the same thing. We have already discussed this. So we are at the end of the session. Anybody wants to comment? Dr. Sanjay, Chintan, Poonam, any final comments you want to make before we close? Chintan, anything you want to add?
What is
Choose your patients well and follow them up meticulously. And thank you for this opportunity. Thanks. Good night.
Thank you. Thank you. Chintan and Sanjay, anything you want to say before we close?
Sir, one thing is if patient has vasodilatation and we want to start the vasopressor agent, either NORAD or vasopressin is preferred post-heart transplant because vasopressin will only increase the SVR and it has no effect on the PVR. And most of these patients have problem with the high PVR and RV dysfunction. So our choice of vasopressor is start with the vasopressin first, then add the noradrenaline if required.
At the small dose, it really doesn't cause a lot of pulmonary vasoconstriction. And you shouldn't be using a large dose of noradrenaline anyway. So, we start with noradrenaline. Our standard is still to come off with dopamine and noradrenaline. That is the first drug we use. And then, as Raghu had mentioned earlier, it is important to keep good perfusion pressure from the RCA. And if you don't have adequate SVR, your RCA perfusion will fall due to a steal that happens in the RCA. So it is best to give a little bit of noradrenaline to keep the diastolic pressure up, and therefore you'll get good right coronary artery perfusion. And vasopressin is nice, but then you should also remember that's going to cause a lot of gut vasoconstriction. It is good for lungs and kidneys.
So not more than 2 units per hour, maximum 2 units per hour. And when you crosses 1.5 units per hour, add noradrenaline to that if vasoconstriction is required. That is what we follow. Yeah.
For kidneys also, it's nice because it has got different effects on the afferent and efferent tubules, the vasculature. So it improves the glomerular blood flow because of that effect. So we still prefer to use NORAD first. You don't want problems with the gut. They don't survive that.
Thank you. Thank you for that. And Sanjay,
Yeah, the other point I think is which is important is perioperatively to maintain goal-directed perfusion, because with that it solves a lot of post-operative headaches as well.
Yeah, I think during surgery, that's a very important thing. I just barely mentioned it. See, a lot of these children who or adult congenitals who come for surgery will have tremendous amount of collaterals. And what we do now is we do a MRI and calculate the RV and LV output based on that. And so preoperatively, we decide what is the pump flow to be given when you're on normothermia. And as you cool down, you can reduce accordingly. So if you don't give appropriate flow and use the goal-directed parameters, you may not be able to maintain good tissue perfusion because they're used to a very large amount of flow. And because of the collaterals, you're just running in circles. You give flow through the aorta, you're sucking out through the left side. So you have to use the parameters like the DO2 and VO2 and ratios and DO2I, etc., to see and make sure that you're perfusing adequately. So sometimes we have aimed at giving 7 liters as full flow. What you must remember is many of our oxygenators don't take 7 liters, even though it says 7 liters. You may have to put a second one in parallel. So this is something which we've been practicing of late. And thanks for bringing that up, Sanjay.
Thank you so much. Thank you so much. And I think it's time to close the session. I would like to thank the moderators, Dr. Poonam Malhotra, Sanjay, and Chintan for being with us, and the speakers, Julius, Murali, Raghu, and Nandita, for their excellent presentations. And on behalf of Indian College of Anesthesiologists, I would like to thank all the participants and the faculty for the excellent deliberations. With that, I would like to close the session. The dinner is awaiting, the virtual dinner. Please, we'll have the dinner and then see you
Thank you,
again
Dr. Mulgite. Thank you all.
sometime later.
Thank you so much, everyone,
Thank you.
for
Thank you so
joining this session. Clanet is
Thank
really
you.
glad to have all these
Thank you,
brilliant
sir.
people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much,
Thank you
everyone.
so much.
Thank
Thank
you.
you.